Hello and welcome everybody to another U of Care podcast interview. It is my great honor and privilege to introduce Dr. Meredith Berry, who is our interviewee today. Dr. Berry, do you mind introducing yourself to our audience?
Sure. Hi, my name is Meredith. I'm a new assistant professor here at UF. I just joined the faculty in 2018. So I'm very much learning the ropes and getting my research set up. So happy to be here and talk to you today.
Awesome, wonderful. So when you initially started at UF, you obviously had a research career before that, got into the field. What got you initially started actually in the field of addiction research?
Yeah, it's a great question because there are so many different factors. And pointing to one is actually difficult. I think that a few that come to mind, though, are definitely just seeing people interact with drugs so differently. So many people try drugs and then don't develop any issues, and it's just kind of recreational. And then a subset of folks kind of go on to develop problems with drugs. And I always thought that was very interesting, just very individual differences in how people respond to drugs and how much they like them and things like that. And the other thing I think that really comes to mind is environment. So much about our environment and how it's arranged and what we find reinforcing really can influence how people use drugs or perceive drugs, and what's bad, what's good. You know, if you just move to different parts of the country, you pick up on cultural differences of interaction with drugs and things like that. So really just a fascination with this overlay and intersection of culture and drug use, and then addiction specifically, and how some people have a really big problem. I think at this point, especially with the opioid epidemic, almost everyone has experienced it, either directly or indirectly with a family member or a friend. I think it's much more tangible now, maybe than it was even a decade or two ago. So yeah.
So a little bit of nature and nurture playing into contributing to potentially the development of a substance use disorder, whether somebody develops a substance use disorder or not, basically.
Absolutely. And it's just fascinating because, you see family members that have a very similar experience, and one develops and one into having a problem, a struggle with drug use, and others don't. And I think it's just fascinating.
Interesting. So what is your current area and focus of research related to this kind of divergence if somebody not chooses necessarily to develop a substance use disorder or not? Because when you talk about nature and nurture and this kind of divergence even within a family, right?
Right. Well, primarily my research area is figuring out and testing sort of adjunctive treatments to existing pharmacotherapies. So for like opioid use disorder, are there better behavioral treatments? Are there better pharmaceutical treatments that we can add on to things like methadone or buprenorphine in human models? And that's kind of where I focus. And I think that sort of interest in the complexity and the diversity come from just talking to people with various substance use disorders, not just opioids, but just their different past experiences. That almost isn't so much an area of my research, but just a fascination with how these things develop and talking to people about their very, very divergent experiences with drugs. So, some people just use drugs to be creative. So I've had long conversations with folks about that. They think it really helps them. One person that I was in one of our studies, he liked it because it really helped him, he thought, write his poetry. So I think, that's really interesting. When we think about drug use, we often think about problems or dependence or things like that, but that's not always the case either. So, yeah.
So when you mention, I think a lot of people associate creativity and opening up the mind with many of the psychoactive substances like LSD, magic
Sure.
mushrooms, peyote, cacti, and stuff like that. Was it in general your experience as well that folks who engaged with drugs like those drugs that they kind of actually benefited from them as well?
Well, there could definitely be, research is showing us now more than ever, that area of hallucinogen research was decades ago very popular, and then kind of went through a bit of a phase where it was not really accepted in a lot of research communities, and now there's kind of a revival of it, so to speak. And there are a lot of therapeutic values to it if used again in a very controlled, monitored setting with a licensed therapist and all that. It's don't want to give the impression that I think that it's just good to go use LSD or psilocybin, but there can be therapeutic value, especially in folks with treatment-resistant depression and things like that. But yes, absolutely, we're like, I would say, a lot of what I study is stimulant and opioids, and folks that have used LSD or hallucinogens, they tend to use them less often. And there's kind of they use, in a lot of conversations that I've had, to be creative, or they think they feel more connected to people around them after the experience, or connected to nature after that experience. So I think that's another interesting aspect, not necessarily in my research, but just the different ways that people use different classes of drugs, and how they interact with environment and people in the process. So, yeah.
Interesting, especially when you look at some of the federally regulated drugs and how they classified in regards to that and their potential impact when it comes to how impactful they are, or how likely they are to cause actually a substance use disorder, or how risky they are in causing a substance use disorder. I think we are kind of rethinking that approach in terms of LSD or psilocybin, actually the likelihood of somebody developing a substance use disorder compared to some of the stimulants when we talk about cocaine or the opioids, obviously being kind of ranking very high in terms of the risk of developing a substance use disorder, right?
Absolutely. Yeah. So I think, and it's recently recognized with the FDA with having some potential therapeutic value. So I think there are strides happening in those areas. I don't do psilocybin research myself, but there are folks doing it in the drug addiction communities, and found that it's, has been helpful for some people with cocaine use disorder and things like that. So I think it's a fascinating area of research, and yeah, my hat goes off to those folks, because I think it's difficult too, because you have to work within a lot of regulatory requirements to get things like that off the ground. So it's another deep layered aspect of research in this area.
Yeah. So where do you see your current research impacting the broader range of addiction research, substance use disorder within the community setting, within patient outcomes? When you, because you kind of at the interface of pharmacotherapy and other therapeutic interventions, and
Right.
I think it's widely recognized that you can't just pop a pill to get rid of your opioid addiction or your stimulant addiction, right?
Right. Absolutely. I think, yeah, a lot of what I see my role in that is just developing more comprehensive care. So one study that we're working on specifically, we are investigating the ability for oxytocin. Most people might be familiar with that, but it's, naturally existing in the mammalian brain. But that as a potential therapeutic to reduce abuse liability of opioids, and we're testing specifically oxycodone. So in that study, we kind of bring people into the lab we test all kinds of things. We think it could also assist with pain management as well. So we're testing sort of these different facets, both abuse potential of a drug and the pain associated, painful conditions that people might have. But oxytocin might be a therapeutic that's less addictive, doesn't have as much addictive potential. So in that case, when we're testing these in the lab, the vision there, I think, is to if hypotheses are confirmed, to develop greater resources towards where this could actually be therapeutic. Perhaps like after someone gets a surgery, for example, if they're prescribed an opioid like oxycodone, maybe they're also prescribed oxytocin, for example, which could maybe reduce their potential of developing a problem with oxycodone or the opioid that they're prescribed. So that's kind of one project. Also working with exercise, just getting more holistic treatments, and we know that exercise helps reduce some painful conditions, helps people sleep better, which can be a predictor of relapse for people in treatment to harmful substance use. And so we're just kind of an obvious question, but it's never really been done in a controlled setting, which I find interesting for opioid use disorder specifically. Just a couple published studies out there, and all of those have sort of ranged in the type of exercise. So we're looking at specifically cardiovascular exercise with the prediction that it will improve sleep and help people reduce sort of anxiety and stress. So some comorbid conditions that we see with opioid use disorder. But so we often bring people into the lab and then hope to apply it kind of in the community. But my first step usually starts kind of in a laboratory setting and then see what happens,
Oh, that's interesting. So any hypothesis of how specifically exercise might actually decrease relapse in opioid? So when you talk about sleep improvement, okay, that's kind of an indirect, but I'm
Right.
thinking about release of endogenous opioids potentially.
Absolutely. Yeah, so exercise we know produces endogenous opioid peptides that bind to all major sub-opioid receptors, so mu, kappa, and delta. So I think, a lot of more research on the molecular level would be great. But me on the sort of behavioral level, I think just sort of speaking to that and what we can pull from animal models, I think it's very, very promising. Just wheel running, it reduces heroin self-administration in rat models and things like that we're really pulling from. And I think, like you said, it could be things happening physiologically, as well as sort of more behaviorally with sleep. And other aspects. I mean, exercise just has a whole host of benefits. So why not make more exercise programs available to people and have that, maybe part of their opioid use disorder treatment in addition to methadone, for example. And that's not typically offered. And of course, there's like a lack of resources and a lot of things that play into that. But if we can offer more holistic treatments, then I think our results would be more promising in keeping opioid use disorder sort of where people want to be using and how often they use and feel like they have it under control. Because really a lot of this comes back to people saying, I'm unhappy with how much I do X. And so we try to help them modify that. So, yeah.
That is fascinating, because I think when I look at it, my interest lies a little bit in kratom, and when I look at kratom as a more user controlled, where users kind of control their consumption and their access to it to some degree, I think of exercise as something that a user can control as well. And when you say holistic, that's kind of integrating the patient into as an active participant instead of you take this, or you are participating with therapy. CBT, cognitive behavioral therapy, is one approach where a lot of the onus is on the patient as being actively engaged, but it's also putting a lot of pressure on them to actually perform, to change their behaviors, whereas exercise is more like you are more actively doing something every day, where you're not necessarily under the pressure to change your behavior on a higher level. I don't know if I'm making sense. You can probably better speak to that much better.
No, absolutely. And that's, it's one of those things that some things work for some folks and other things work for other folks. And that's the trick, right? Making things accessible and easy for people to do, because, even, in my life, I know I should meditate more, but I don't, right? And I think a lot of people can relate to that. But it's the same with exercise, right? I probably should have woken up early this morning to exercise, but kind of didn't, but I set my alarm too, so it's, it's one of those things that, when we infuse these treatments, the easier, more accessible, the better, really. And different things, again, are going to work for different people. So I think we, creating and sort of testing these things with an eye towards more precision application with where it's going to work and for who it's going to work for. So, yeah.
So you already addressed some of the limitations that some treatments may only work for certain patients, but where do you see the main barriers for your research, and what limits kind of your research being more broadly available, and also how it can be translated and then applied into clinical practice?
I think a big barrier just in general in sort of addiction is stigma. That's a difficult one. It just affects like our ability to recruit, things like that, support from various venues. Whereas if you were, investigating some of these things in a cancer population or whatever it may be, the same stigma sort of doesn't come along with that. So I think barriers to resources that is one issue, right? If we're gonna create a treatment and sort of broadly apply it is often a case of resources. And I think the lack of resources in some ways is influenced by sort of stigma associated with addiction. But other things too. I mean, a lot of things are underfunded that should be, more resources should be going to it. But right, when we're talking about large scale application, it does become difficult, because then, where's that money going to come from if we're going to equip opioid maintenance treatments clinics with X amount of treadmills and perhaps like a personal trainer to sort of oversee folks who want to exercise, things like that. I think it, often comes down to money. Yeah.
Yeah, I think that's a general concern that many of us face. Stigma is a big issue for, I think, most substance use disorder patients.
Absolutely.
That's what I've heard from many other interviewees, many of our colleagues as well, in recruiting and also getting the word out in clinical practice, of translating it, and also money, just support for studies.
Right.
And that's
exactly.
We'll have to see where things are going, and hope that for the better that the public is seeing a need for this. I mean, I guess one unfortunate outcome is that we are being reactive when it comes to, for example, the opioid epidemic and the spike in, unfortunately, the worst possible outcome, overdose deaths, that kind of trigger a reaction, and hopefully being more proactive in preventing overdose deaths. So that's a big topic, I think. Yeah.
Absolutely. And I think the overdose deaths have really brought a lot of attention to it. And so I hope that, with the distribution of Narcan and things like that, we're starting to see some of those in some populations and some communities sort of level off instead of continuing to increase. So there's some positive signals that we're getting, but it is still very much, an uphill battle with fighting that in a lot of ways. But the availability of Narcan and the more, states and cities and communities can get that out to the public, I think is a fantastic thing.
Okay. Let's hope that we can continue to stem that tide, and hopefully we'll see a downward trend at some point too.
Yes, absolutely. That's the hope.
Okay. So thank you so much, Dr. Berry, for making yourself available. And I really look forward to seeing a lot more, especially in terms of the exercise. I could use some exercise too. I probably alarm earlier in the morning as well. So I'm right there with you. Thank you so much for making yourself available and for this fascinating interview. Thank you everybody for listening, and look forward to the next UF podcast with another UF Care member. Thank you everybody. Take care.
Thank you.